Thank you, Stephen, for the introduction, and thanks for the opportunity to be able to speak to you all. The outline of this talk will deal with, first of all, the problem, but I'm sure you're all very aware of the problem. I'd like then to concentrate on ways of preventing it, because this is an overview of prevention of preterm labor. Looking at primary prevention, in other words, preventing labor starting in the first place. Secondary prevention, preventing the delivery of the baby. And tertiary prevention, preventing damage to the baby after delivery. And then I'll conclude with what actions we can take now which will make a difference. But first of all, the problem, and this is a slide which I must thank Jeffrey Smith for, and the following two slides as well. But it comes from the paper in the New England Journal of Medicine looking at preterm labor. And basically this is in developed countries. And I think the important point here is this 1% of the increase in preterm labor is unknown. That's starting at a base of about 10% going up to 12%, but half of that is unknown. There are other increases in the thing like assisted reproduction, increasing maternal age. But the worrying part is why we know so little. I think the next slide is also important in that in developed countries, and the studies have mainly been done in developed countries, they feel that there's very little chance to improve or prevent preterm deliveries. Now, I think what's important, and I'm glad this conference is in a middle-income country and it has a very large developing part to it, is that this research is mainly in developed countries. What is the situation in the developing countries? Is the problem not much greater there? And I think it's summarized very well in this bottom sentence. One of the interesting parts I find about this preterm labor is that the majority, there are rich countries or developed countries, high-income countries, which have a high preterm labor rate, which we can see here with the United States, and I think Brazil we should also regard as a developed country, and China pretty much coming into developed countries. Those contribute a large numbers to preterm birth, but still the majority of the preterm births are from the developing countries, the low-income countries. Now, I like to break up preterm birth into two groups. The one is the iatrogenic, the ones that we deliver because we need to, and the other is the spontaneous. Now, I'm not going to go into detail in the iatrogenic group. This is a group where we have to deliver to save the mother's life. So if the mother has severe preeclampsia, that's hypertension and proteinuria, we need to deliver the baby so that the mother can recover. There are effective interventions to prevent this. We can use calcium supplementation and antenatal care. That's clearly been shown to reduce the prevalence of preeclampsia. And we can also use low-dose aspirin in cases where there has been a history before of hypertension. There's also times when we deliver the baby because it's for the baby's well-being, to save the baby, and that's where there are some congenital abnormalities or diseases like rhesus immunization. Again, we can prevent that by giving anti-D. However, I'm going to concentrate on spontaneous preterm birth because that is by far the biggest problem. So if we look at primary prevention, that's trying to prevent labor, preterm labor in the first place. One option is to identify the woman at risk during pregnancy, but unfortunately our risk factors or identification is pretty poor. The best risk factor for preterm delivery is if you've had a previous preterm delivery. That means you rule out all people in their first pregnancy when they're most likely to develop a preterm delivery. So we have very poor mechanisms of identifying women at risk. However, where we do identify women at risk, we can treat either by using a cerclage or progesterone. We can also modify risk factors in the pregnant woman, and that would be by changing lifestyle, trying to stop smoking. Can't do much about obesity, but we can screen for asymptomatic bacteria to treat and prevent urinary tract infections, the sexually transmitted infections, gonorrhea, for example, or other causes we can detect and treat, very difficult to do, and then also HIV and malaria are associated with preterm delivery. But in real terms, the best predictor that we have at the moment is one very difficult to achieve, and that is to measure with ultrasound the cervical length. And I'll come back to that. If we look about the risk factors prior to pregnancy, this is the area where we can probably do our best work by birth spacing, by preventing teenage pregnancies, but we can't do very much about the socioeconomic conditions of the people. But if we prevent preterm birth by teenage pregnancies, preventing pregnancies or increasing the birth spacing, we will have probably a bigger effect than risk classifying the mothers. Right, so our primary prevention is we can't actually change a large number of the risk factors while the woman is pregnant. We can't change the socioeconomic factors. We can't change the contraceptive use. They're already pregnant, so we can't do anything about that. And our biggest problem, we cannot really risk classify the patients. We can't identify high-risk women. We can identify some groups, notably those who have a short cervix. Now, to do that, you need to do ultrasound. You need to screen all the women. You need to screen 20,000 women to get about 200 women who are going to have a short cervix. But if you do that and you treat with progesterone, you will prevent preterm delivery in 20%. That is the only real intervention that will make a big impact, but it's a first world intervention. Right. It's not really effective. So if we look at secondary prevention, and that's preventing the delivery, our first option is to suppress the labor, to use tociolytics. There are a number of the tociolytics. Nifedipine is probably the most popular one at present as calcium channel blocker. Indomethacin is the most effective in that it is the one in the Cochrane trials that has been shown to prevent death and decrease neonatal morbidity. But it has a large number of side effects, both to the fetus and the ductus venosus, ductus arteriosus, and to the kidneys of the fetus and the platelets, and also side effects to the mother. Atosiban is a very, very effective drug. It is, has the lowest side effect profile, but it's extremely expensive, so not really available to the developing countries. We can try and treat the cause now in developing countries. About 50% of preterm labor is related to an infection. And so if we treat the women with antibiotics, theoretically we would prevent preterm labor. Now there's some debate about this. I don't think there's any debate about the use of antibiotics in preterm premature rupture of membranes. That's clearly been shown to prolong the latent phase from the rupture of membranes to the start of contractions, and also to decrease neonatal morbidity and maternal morbidity. The issue goes around that of antibiotics. Now there are two trials. Oracle trial, in which most of the conclusions are drawn from, is a trial based mainly in developed countries. The prevalence of infection causing preterm labor in that population is only around about 15%. And in that group of patients, 50% in their trial did not have any cervical dilatation. They started on treatment with symptoms rather than clear signs, and we wouldn't have regarded them as preterm labor. There is another trial conducted in South Africa a number of years ago looking at antibiotics with preterm in women with preterm labor, and in those the antibiotic was ampicillin. There was a prolongation of the period from birth to from starting labor to delivery of 14 days compared to the 2 days of the group with placebo. In that population, 50% of the group had infection as the underlying cause. So the Oracle trial, which most is based on and which is used in the Cochrane database, didn't have the power to look at infection and the place of antibiotics. But long-term follow-up in the babies in the Oracle trial have shown that there have been some neurological effects. There were more babies with cerebral palsy in the group that got antibiotics than others then didn't get antibiotics. Tertiary prevention, right? We can give we can give corticosteroids. I'm sure you're all familiar with that. We can give antibiotics. I've mentioned that. And we can give magnesium sulfate. Now, this is a very important, again, this is a very important intervention in the sense that in developing countries, those babies who have minimal brain dysfunction will get worse, whereas in developed countries, there's facilities to treat them. So we really should be, in developing countries, promoting magnesium sulfate. And of course, there's the in utero referral. After birth, delayed cord clamping and neonatal resuscitation. There are a number of ineffective interventions, which I won't go into. So our actions that we need to do are, first of all, a collaborative effort, and this means that we need to change or alter the lifestyle, promote contraceptive use, and in the contraceptive use, when we're talking to people, we should be mentioning that if you space out the families, that you'll have less preterm labor, you'll have less complications in birth. And we want to prevent teenage pregnancies. In terms of interventions which you should be using now, well, primary prevention, birth spacing, contraception, and lifestyle modification. During pregnancy, lifestyle modification, and trying to identify those risk factors. In other words, doing midstream urines to identify asymptomatic bacteria and treating it. During labor, we should try and prolong labor as long as possible so we can give antenatal corticosteroids. We should give antibiotics for preterm premature rupture of membranes. We should use magnesium sulfate for neuroprotection. And if there's time, we should transfer the babies in utero to a more appropriate center. After birth, delayed cord clamping and neonatal resuscitation are key aspects, and then the further care of the preterm baby, which one would go into later. I'd like to thank Jeffrey Smith again for the slides, and then just some references. I think the key reference there is the Cochrane library. If one looks at all of these interventions, there are good systematic reviews, and you can see what is effective and what's not effective. Thank you.